So this is our second podcast with the child with altered cardiovascular and hematological status. We were talking about pulmonary hypertension. Children with pulmonary hypertension and families will need support and education. And we talked about a lot of things that they would need. They will also need financial support. So to be quite honest with you, some of these medications can run about $25,000 per month. If some of those continuous IV infusions of the medications run $25,000 per month. So that is significant. We need to help the family and help set up the family with resources that are available to them. Prepare them to perform or prepare them for complex therapies and follow-up care. This is something that their child will need continual monitoring for. All right, so congenital heart defects is not one diagnosis. Well, yeah, there's lots of different things that fall in the category of congenital heart defects, okay? It depends on the area of the defect, on what the classification is, all right? We're going to talk about that in just a minute. General signs and symptoms will depend on the severity of the defect, mild to severe, right? If they have very mild defects, medications might be used and might be fine. If they're more severe, they may require surgery or heart transplants. All right. Again, there is a nice list. It's a table in your book. I'm not going to test you on those, but it's really good. So you might want to look at it prior to the NCLEX because they can pull up these congenital heart defects, and you're going to think, oh my gosh, they're making up a word. Page 1084 to 1094 in volume 1 of your Pearson manual, or your Pearson book, excuse me. All right, so here's the classifications I was referring to several times, okay? So we have an acyanotic congenital heart defect. All right, you won't see these necessarily used anymore, these terms, but these classifications are wonderful in order to separate the different types of congenital heart defects, okay? Just like if I tell you antihypertensive, you're like, okay, what is it? An ACE, an ARB, a beta blocker, what are we talking about? But if I tell you a beta blocker and I give you that category, you can tell me very specific information, even if you don't know which one I'm talking about. It's a very similar concept here. So acyanotic is when the blood is shunted from left to right, okay? This is when the blood has already been oxygenated and it is shunted back to the right side of the heart. So it goes back through that pulmonary circulation again. There's an actual increase in pulmonary blood flow. What that means is those lungs are working twice as hard. All right, so they're working very, very hard, but the blood that is pushed out is going to be oxygenated. All right. Cyanotic is when the blood is shunted from the right to the left. The blood has not yet gone through pulmonary circulation to get oxygenated, so the blood that is sent out by the heart is not oxygenated. And there's varying degrees. There's very little blood oxygenated sent out to a mixture of blood that's sent out that's oxygenated. This is considered a decrease in pulmonary blood flow. All right. So those are your two main categories. And all those defects fall within one of those categories. So if we're talking about acyanotic, you can see there our increase in pulmonary blood flow, and you can see all the things that are listed. Again, if you want to know more about these, they are in your book, and I already gave you the page. But we are going to work through the ventricular septal defect. And as far as cyanotic heart defects, which has a decrease in pulmonary blood flow, we are going to work through the tetralogy of flow. Okay? So those are the ones we are going to work through, even though the other ones are listed for you. I apologize. My dogs are very worked up today. I think it's going to storm outside, but I apologize for that. So, discussing increase in pulmonary blood flow and ventricular septal defect. This is the most common of the congenital heart defects. 1 in 240 babies in the United States have this, okay? It is a hole into the ventricular septum, all right? You usually do hear a loud, harsh murmur, not a loud murmur, but a loud, harsh murmur. Mild defect may spontaneously close, but if more severe, may require surgery to close. Most can be done through catheterization type of procedure, but it will depend on the defect, okay? This will require prophylactic antibiotics to prevent bacterial endocarditis. So those are the patients who have to have antibiotics prior to going to the dentist to prevent that bacterial endocarditis. It is an infection in the heart itself, and the valves does destroy the valves. Children, depending on their age, if you need to teach them about surgery and their congenital heart defect, you would use maybe a doll with a sternal dressing, an incision, to talk about how the doctor's going to fix their heart. All right. So depending on their age is depending on how we're going to educate them. And we've talked about that before, but oftentimes we'll use dolls and visual aids like that are less scary. Child life specialists at Hershey have these wonderful dolls that they can put, they're like felt, and they can put like central lines on them. They can put dressings on them. They can put ostomies, like they can put all these things on them, and it really helps the child become a little bit less frightened and more comfortable with what's going to happen. Okay. All right. So when we are in class together, we are going to watch the ventricular septal defect repair video. All right. Together. But you can see where this defect would be. All right. Now, this is a picture of Mrs. Filburn's niece. All right. Her niece is named Megan, and she is our director of nursing for Hack Nursing, right? Her niece had ventricular septal defect, and you can see how she is shorter and looks younger. So her growth and development were stunted from this cardiac defect. But after the repair, you can see here, and I can't believe she's 13 in this picture, but you can see here how she very quickly caught up. This is why it's so important to make sure they stay on a good growth and development. Because if we didn't care about that, her being able to catch back up would be much more significant, okay? So we want to make that as easy of a transition as possible, all right? Now, the other cardiac defect we're going to work through, which is a decrease in pulmonary blood flow, is the tetralogy of flow. This is 4 defects in one. You must have all 4 defects, no matter what varying degrees, to have tetralogy of flow. It is a cyanotic heart defect. You can see there the ventricular septal defect and an overriding aorta, hypertrophy of the right ventricle, and stenosis of the pulmonary artery. So the one we will have already discussed is the ventricular septal defect. This does require a surgery. I shouldn't say it does require surgery to repair, and we'll watch a video on that in class. You do have access to all these videos. All you have to do is download these PowerPoints off of D2L, and all the links will be live for you. So you can do that if you want. We're going to watch a video. I will tell you that what they do is they wait as long as possible to do the surgery, because the older the child, generally, the better the outcome with these heart surgeries, okay? So they might only fix one of the big ones. So maybe they're only going to fix the overriding aorta as an infant, and then they'll wait, and then they'll fix another one based on need, and they'll do it that way. Or if their defects are such where they have to do multiple things in one surgery, they might fix 2 or 3 of these defects. But understand that the more surgery they have, the good prognosis will go down, okay? It continues to lower the more complicated the surgery, okay? Additionally, children who have had surgical repair of tetralogy flow may need later repairs as they get older, but they will absolutely need to be followed by a cardiologist for the rest of their life. This is very important for the parents and the child to understand, because oftentimes when the children leave their home, so they're grown up or they're going to college, they don't have health insurance. They're young, they're in their early 20s, they don't have health insurance, okay? This is very common. And they don't really think they need it because they're generally healthy. But children who have had tetralogy flow and or repairs related to it will always need to be followed. They cannot go without cardiac monitoring. All right? And when I say monitoring, I mean being seen by a cardiologist routinely to make sure that everything is still working properly. Things happen, scar tissue forms, things become less compliant, so you never know what might be needed to be revised. They'll also probably need to be on cardiac medications, so that's very important to explain to parents and children. This is a picture of where the defects would be. So this is where it's thickened. And here's our ventricular septal defect where we saw before in our other picture. An overriding aorta. And there's our pulmonary stenosis where it's very much closed off, okay? As far as symptoms, you can see there, cyanosis. Usually this is diagnosed very, very early, all right? So one of the first things that you might see is the child unable to feed, when every time they start to breastfeed or get bottle fed, they will stop because they need to be able to breathe, okay? And their heart's working too hard, so they just don't have the stamina for it. Clubbing our fingers and toes, we already talked about that, being over longer periods of time. Dyspnea with feeding, that's what I just discussed. Squatting episodes. So squatting episodes, and this is what we're looking at here, are where the child brings their knees to their chest. And this is what they do to increase peripheral vascular resistance. So what's going to happen is it's going to help shunt the blood back up to the heart to try to help to get it oxygenated. So the blood gets shunted back up to the heart, in hopes that it goes through the pulmonary circulation again and it gets oxygenated by the lungs and then sent back out with oxygen, carrying oxygen, but that is not always what happens and not often what happens. Those hypercyanotic episodes are what we call TET spells, T-E-T, spells. They are when the lips, hands, feet turn blue, just like in this picture. This is caused by a rapid drop in the amount of oxygen in the blood. And if they are having one of these hypercyanotic episodes, if you put their knees to their chest and give them lots of oxygen, it does help. All right. They will show signs and symptoms of congestive heart failure, frequent respiratory infections. They will be making more red blood cells. So they will have polycythemia. The body is trying to compensate by making more red blood cells to carry that oxygen molecule, okay? Although that's not what happens. And here is one of the types of repairs. If you're interested, feel free to watch this video. So when these children have these cardiac repairs, it can be very scary for the parents to see. But this is the first 24 hours. And more likely than not, after that, a lot of these things start disappearing very quickly, okay? They'll lose a lot of these tubes very quickly. This is the same little girl who's standing here, okay? So they bounce back fairly quickly with no complications, okay? But here are how the tubes look. As you can see, these are the drains that are present to help prevent pericardial effusions, and that's one of the complications of cardiac surgery. All right, it's developing a pericardial effusion. Here's a picture of it, and this is normal pericardium. There you can see it's an abnormal accumulation of the fluid in the pericardial cavity, okay? Causes of this include cardiac trauma, cardiac surgery, transplants, immune or infectious diseases like HIV, cancer, so immune diseases like cancer, inflammatory diseases like bacterial infections. Those are all causes of pericardial effusions, okay? Symptoms usually include chest pain, difficulty breathing, anxiety, palpitations, tachycardia is a big one. This is usually treated with high-dose NSAIDs, all right? These can resolve on their own, but they may have, if they are drained, they may refill. So even if they drain the pericardial sac of the extra fluid, it could just come right back. Not only do they use high dose NSAIDs, but they use colchicine. Colchicine, and I'll spell that for you, it's C-O-L-C-H-I-C-I-N-E. It's an anti-gout agent that reduces, it's very effective for this, it reduces the inflammation around the pericardial sac. Diagnosis is with symptoms, an echocardiograph, a cardiac MRI, or cardiac CT. Those are the ways you diagnose this. We are going to stop right there, and when we come back, we are going to talk about the concept of cellular regulation.